This program is brought to you by Emory University.
Good afternoon, everyone. I am Sandra Pernetz. I am one of the sonographers for the Adult Congenital Heart Center, and it's an honor for me to present these congenital cases. Today, we're going to start with the simple and moderate cases, and I appreciate Dr. Aslam for the invitation, for allowing me to share the knowledge with you guys, and we're going to get started. Thank you for being present in this Zoom meeting. I have no disclosures. And the objectives of today's meeting will be understanding the echo features of the atrial septal defects, the ventricular septal defects, patent ductus arteriosus, bicuspid, unicuspid, and quadricuspid aortic valve, coarctation of the aorta, pulmonary valve stenosis, Cor Triatriatum Sinister, and anomalous coronary. So for the atrial septal defects, there are several types. So we have the Ostium Primum ASD, that it's located in this region of the septum, right in here. The Ostium Secundum ASD, which is the most common one. The superior sinus venosus ASD, the inferior sinus venosus, and the unroofed coronary sinus. So we'll go through examples of all of them. Starting with the Ostium Primum ASD. So in the peristernal long axis view, you can appreciate that the mitral valve appears to be thickened, and there are some characteristics of this which are cords attached to the ventricular septum. The right ventricular appears to be somehow dilated, and there is some degree of regurgitation due to cleft mitral valve associated with this type of lesions. So in the short axis view, you will appreciate some D shape of the ventricular septum due to the volume load of the right. There's a dilation of the right ventricle, and there is a cleft mitral valve along the anterior leaflet, you're seeing right here. We'll have some examples on 3D. As we tilt the probe over to the inflow view of the right ventricle, you can start appreciating that there is a defect along the primum septum, close to the AV valves. There's also a degree of mitral regurgitation seen here in blue, and the red flow showing a left to right shunting. And the aortic valve is right here, that shows no AI. I am putting a lot of 3D images because I feel like we can understand better the anatomy and gives us a better landmarks of the other structures surrounding the defects. For example, this one shows the left atrium here, the large primum ASD, the aortic valve, and this is the right ventricle. On the 4-chamber views, you're going to appreciate that the right ventricle and the right atrium are dilated, but also you have a defect right across the crux of the heart near the AV valves, and you appreciate that the AV valves are at the same plane, not quite apically displaced of the tricuspid valve. This is the characteristic of this type of defects. Also here on top, I put a normal 4-chamber view so you can appreciate the difference between the normal septing of the atrial septum and the defect and the primum. On the subcostal view, for other hand, you can see that there is a left to right shunt along the primum area of the septum. The AV valves are at the same plane, and the red flow showing the shunt, and some degree of TR as well in here. With the 3D, we can appreciate the different types of cleft or degree of cleft along the anterior leaflet of the mitral valve. For example, here you see that there is a small cleft compared to this other case where the cleft goes all the way deep into the curtain of this anterior leaflet of the mitral valve. Also notice that there are a lot of cords attached to the septum. Usually the mitral valve should not have any cords attached to the interventricular septum. Moving to the next type of ASD is the Ostium Secundum ASD. So when you start looking at the parasternal long axis view, you will appreciate that there is a dilation of the right ventricle, and the left chamber seems to be normal. As we move to the short axis, we see some degree of D-shape of the ventricular septum. The right ventricle appears dilated, and the ventricular functions are normal. When we move close to the base of the heart, where the aortic valve and the atriums are, you see that there's a defect along the secundum septum with the left to right shunt seen here in red. Here are the pulmonary veins draining into the left atrium, and here is the aortic valve and some degree of tricuspid regurgitation. What's important with this type of secundum ASD is this is the ASD that can be closed percutaneously in the cath lab. So it's important that we document the rims, landmarks of other structures to see if it's safe to close percutaneously. So in this view, we're looking at the ASD from the atrial side. We can appreciate this is the inferior vena cava, the secundum ASD, the rims along the aorta, the superior vena cava. So this is actually a very nice case to be closed by percutaneous approach. In the apical four-chamber view, we can appreciate that the right-sided chambers are dilated compared to the left, but also we can see that there's a defect along the secundum area, and there is a left to right shunt with a trivial degree of tricuspid regurgitation. And in this subcostal view, we will appreciate, again, the secundum defect. This is the right atrium, this is the left atrium, and the left to right shunt. We cannot see very well the right or the left ventricle. We were focusing more with the defect. This is the ideal view, subcostal, because your Doppler is completely parallel and you can assess better the presence of this type of defect. Moving now to the superior sinus venosus ASD. Some of the slides will have a normal heart on top, so you can actually see what the normal versus an abnormal ventricles look like. This particular case has a very dilated right ventricle. There is a prolapsed mitral valve with some thickening, but there's also a very dilated coronary sinus because sinus venosus ASD can be associated with persistent left SVC. So the persistent left will drain in the coronary sinus, dilating it, and this is the appearance on the echocardiogram on the parasternal long axis view. As we move to the short axis, you can appreciate the ventricular function, the right ventricle dilation, the very D-shaped, because this patient also had some pulmonary hypertension associated with her defect. So you will have D-shape in systole and in diastole. She also had a degree of pericardial effusion. On top here, you can see how a normal short axis should look like compared to this abnormal D-shape. In the four-chamber view, you can only appreciate the dilation of the right-sided chambers. However, you don't see any kind of defect either in any area. So this is not the plane or the view that you should perform to assess this kind of defects. And this is why people missed sinus venosus ASD on echoes, because we have to go and do more specific views like this one, which is the subcostal view, angling very anteriorly close to your pulmonary arteries and your SVC so you can appreciate the defect along this area. This is your SVC flow seen in red, and also there is the right upper pulmonary vein will be draining abnormally into the right atrium, and then you can see that the right atrium appears to be much larger than the left. This is the right pulmonary artery. So important with this type of defects is to look at the drainage of the pulmonary veins. This one is the right lower pulmonary vein. It's draining normally into the left atrium. But when we tilt a little bit anteriorly, so it's sort of like in the 5-chamber view, we see that the right upper pulmonary veins now appears to be draining into the right atrium and not into the left. Then another view from the subcostal, we can see the bicable, IVC and SVC, and the large defect right in here in a left to right shunt. And in this nice 3-dimensional imaging, we can appreciate the defect along the left atrium, the right atrium, and the SVC. So I want to emphasize there's a myth that we cannot rule out sinus venosus ASD by echo. That is a lie. There's always, the patient has a window, there's always a way of finding this defect. We just have to use the right images, and sometimes the right parasternal that is underutilized is very important in this kind of situations. If the patient doesn't have good windows, of course, it's a limitation, then a bubble study will be performed. For the inferior sinus venosus ASD, those defects are very rare, and they are located near where the IVC and where the eustachian valve is here. In this case, is a little bit more prominent, maybe considering a partial Cor Triatriatum dexter in this case. But you see that there's a defect along this inferior portion of the septum, and the color Doppler suggests that there is a left to right shunt. Now, these defects can be associated also with secundum ASD, large secundums, where the inferior portion of the septum, if you look up here, the secundum is missing and is extension to the inferior sinus venosus, and the pulmonary veins, lower pulmonary veins, are draining now into the right atrium, but also the whole inferior septum along the secundum is missing in this case. And there is another case where there was a smaller size of the inferior sinus venosus, and the best way to look at this are the subcostal views near where your IVC is draining. In the right parasternal views is a key view because we can appreciate the right atrium, the inferior vena cava, and this defect along the inferior sinus venosus. And the color, of course, will let you see the left to right shunt or right to left if it's present. The unroofed coronary sinus is the most rare type of ASD, and there is a unroofing, like the word it says, of this sinus as it enters along the posterior part of the heart into the left atrium. So when you put the color in the parasternal long axis view, you start to appreciate that there is an unusual blue flow into the coronary sinus, that it's coming from the shunt of the left atrium into the CS. In this short axis view, as I move up towards the groove of the heart, here is where the coronary sinus will come into the right atrium, but you see that there is a type of defect, a very unusual flow, blue flow from the left atrium into the coronary sinus. This atrium, there's a right ventricle also appears mildly dilated. So we perform bubble studies to rule this out, and you can see that this agitated saline from the left arm was draining into the coronary sinus and directly into the left atrium. I'm going to let it play again so you can appreciate the shunt. And in this 3D, we can truly appreciate the unroofed sinus, coronary sinus here, and the left atrium is below in this area, and this is the right atrium. So I'm going to let it play because I think these are the most unusual type of defects, and they're very rare and difficult to find. Moving now to the ventricular septal defects, we're going to look at all the types. The type 1, that is also called the subarterial, coral, supracrystal, doubly committed, or outlet type of VSDs. Type 2 is the most common one, is the perimembranous or membranous VSD. Type 3 is the inlet or atrioventricular type, seen in common AV canals. Type 4, the muscular VSD. And the most unusual one is the Gerbode, which is a left ventricle to right atrium type VSD. So let's see some example of those. The type 1 VSD is the doubly committed or the supracrystal, and it's located more near to the right ventricular outflow tract. And it can be associated with aneurysms of the right coronary sinus, like you appreciate in this view. So the parasternal long axis, and here is the defect, the aortic valve, and this tissue is a sinus of Valsalva aneurysm. So when you start to look at an echo and the patient has a VSD, just this view can tell you that this was an outlet VSD and not a membranous VSD. When we put the color Doppler, we can appreciate the shunt with this turbulent flow within the septum. It's a left to right shunt, but also you can appreciate that there is a very eccentric jet of AI, and that's due to the instability of the sinuses because the sinus is being sucked through the VSD into the right ventricular outflow tract. I put the clock here because it's an easy way to differentiate a membranous from a type 1. So at the level of the base of the heart, of the aorta, between the LVOT and the aorta, you're going to start to see that the defect is closer to the outflow tract than the inflow of the right ventricle. So this is a type 1 or outlet VSD. All VSDs are going to dilate the left-sided chamber. So on your 4-chamber view, you will appreciate that the left atrium is much larger than the right, as well as the left ventricle. In my experience, I've encountered that the atrium, left atrium dilates first than the ventricular, than the left ventricle. So just pay attention to those chambers. Patients can present with AFib due to the atrial dilation. And these VSDs can have some complication, and one is a rupture of the sinus of Valsalva due to the aneurysm. And you can see 2 jets by color at the level of the outflow tract. One represents the VSD, and the other one is the rupture of the sinus. And see how the flow goes directly into the outflow tract. The Doppler is going to demonstrate the continuity flow due to the fistula or rupture of the sinus, as well as the VSD. And I have a very nice example of this transesophageal done in this patient where you can see the rupture sinus and the doubly committed supracrystal VSD once the valve opens. So it's a very rare complication, but it can present with this type of defects. So moving to the type 2, it's the membranous or perimembranous VSD. This flow looks very similar to the previous one, but the location is a little bit more towards the 10 o'clock. And you see in the parasternal long axis, the defect in the most proximal portion of the membranous septum, and it's a left to right shunt in this case. When we go to the short axis view, you see the clock here. It's a defect is going to be more towards the 10 o'clock, and it's a left to right shunt. And here's your left atrium, your right atrium, and some degree of tricuspid regurgitation is present. So with the VSD, the Doppler, we can estimate the right ventricular pressure because the gradients will reflect the pressure on the right ventricle. If it's a high gradient VSD, that will suggest that the ventricular pressure on the right is normal. But if it's a low gradient VSD, then it's presumably there's an increase of right ventricular pressure due to probably pulmonary hypertension. Or in another way of estimating the RVSP is subtracting your systolic blood pressure minus the VSD gradient. In this case, the gradient was 104. So most likely this patient had no pulmonary hypertension. This type of VSD can be spontaneously closed by the septal leaflet of the tricuspid valve, as it's seen in this example. This red flow is just swirling within the LVOT, but never reaches the ventricular side of the right ventricle. But sometimes can be just partially spontaneously closed, and the septal leaflet redirects the blood flow from the LV through the VSD, partially closed, into the right atrium. What's important to recognize is that the Doppler will record the left ventricular pressure and not the right ventricular pressure. And I want to emphasize this because we have encountered patients who are referral to the center due to pulmonary hypertension, and the patient did not have that. All they had is a communication between the LV and the right atrium from the partial closure of the VSD. The other complication that is very common is the double chamber right ventricle. In this example, there is a large ventricular septal defect membranous, and you see that there is a turbulent flow into the outflow tract, and that's because of these muscle bundles that are created from the, one of the hypotheses is probably just that turbulent flow against the wall of the right ventricle. And in this short axis, you can appreciate that there are two chambers. That's why it's called double chamber right ventricle, the inlet chamber and the outlet chamber. And this significant obstruction into the outflow tract. There's also some D shape of this left ventricle. You can see what a normal heart should look like compared to this double chamber right. There's another case where the VSD was closed, but the patient developed double chamber right ventricle, and it was significant obstruction. This is the 3D demonstrated. This is just the orifice into the out to the outflow tract. The other complications will be a subaortic membranes that form and aortic insufficiency. So just VSDs are not just VSDs. They can actually have some complications that are important to recognize. The other type of VSD is the inlet VSDs, and they are associated with AV canals. And in this parasternal long axis view, you see that there is a very large portion of the inlet septum missing. There is a plane of your AV valves are equally the same, and there's also a primum ASD. So this is what we call a complete AV canal. And I put a normal parasternal long axis on top so you can see the difference of what a normal versus a type 3 inlet VSD. In this short axis view, you will see the defect along the inlet view or the inlet septum, and this is a common AV valve. The valve has not been divided. It's a cushion type defect, and then you will see the shunt is, in this particular case, a left to right. And also there is a primum ASD in this area. On the 4-chamber view, you have the normal heart on top. And then on the bottom, you'll see that the right ventricle is dilated. There is also some right ventricular hypertrophy, maybe due to some pulmonary hypertension. And then you can see the primum ASD and the inlet VSD, and the AV valves are at the same plane. And in this 3D, you can appreciate the common AV valve. So the valves have not been divided. It's a cushion type defect. So another type of VSD is the common one is the muscular VSD, and as the word says, it's along the muscle of the septum, and it can be in any portion of the septum. This is more towards the mid-septum, and this other example is more towards the base, close to the membranous septum, but it's in the muscular area. and the color demonstrates a left to right shunt with a high velocities, indicating that this is a restrictive VSD. So they're very small. And in some cases, you can see the defect, but you don't see the flow because as the heart contracts, it actually precludes from the blood to shunt from one side to the other. And the last type of VSD is the very rare, and it's called Gerbode VSD. And it's the VSD that it's allowed from the tricuspid valve being apically displaced normally. Then you will allow the left ventricle to shunt into the right atrium, which is seen in this area here. This patient has also a very tiny primum ASD. That's why you see this red color between the left and the right atrium. But the defect is right in this particular region. And it's LV to right atrial shunt. So let's move now to the ductus arteriosus. The ductus arteriosus is also called ductus Votali. It connects the trunk of the pulmonary artery to the proximal descending aorta. It's part of the fetal circulation. And a few days after birth, it closes, forming the ligamentum arteriosus. But in some situations, in some cases, this ductus is patent. And the best view of the echo to demonstrate that is the short axis at the level of the pulmonary arteries, where you can see the right pulmonary artery and the left pulmonary artery and the descending aorta below. When you put the color Doppler, you will see a continuous flow from the descending aorta into the main PA, demonstrated in here by color. In this example, you see that this is the outflow tract, this is the pulmonary valve, and then you see that the PDA flow is running along the lateral wall of the main PA and going underneath the pulmonary valve and coming back into the main PA. I thought this was a very cool vortex of the blood flow within the PA due to the ductus. The continuous Doppler will show a continuous flow because the blood is going from the descending aorta into the pulmonary artery. These velocities will vary depending on what the pulmonary arterial pressures is at the time. In this case, the patient did not have pulmonary hypertension, allowing a very high velocity from the aorta to the PA. This type of shunt will give left-sided chamber dilation because it's an extracardiac shunt. And like you see in this case, there is a left atrium dilation as well as the left ventricle, but there is preserved ventricular systolic function. In the suprasternal notch, you will encounter the arch here, the descending aorta, and then you will see this patent ductus with the flow going from the aorta into the PA in a very high velocities. And here is a 3D demonstrating a very large ductus. And when the ductus is presented in adults, sometimes it's really hard to close percutaneously if it's a large one like this. So the way of closing this will be surgical. Let's move now to another theme, which is bicuspid aortic valve. This is the most common congenital lesion well seen in young adults. And in the parasternal long axis, you can appreciate the doming of the aortic valve, as well as some thickening. And it can be associated with stenosis or insufficiency. The biplane here will demonstrate the view of the long axis doming of the valve, as well as the short axis where you can appreciate some of the raphe between the right and the left cusp. And then the larger cusp will be the nun. And the valve will open in a more oblong or non-circular way. The normal aortic valve will have more like a triangular opening, which you don't see in this case. Here's some three-dimensional image of a bicuspid valve from the left ventricle looking up into the leaflets, and you will see the doming and the opening of the aortic valve. From the aorta looking down to the leaflets, you will see the raphe, and here are some thickening also of some areas of the tips of the valve. What's important in this case is measuring the size of the aorta at different levels, at the outflow tract, and at the sinus, the junction, but important so it's go high in the peristernal so we can see the ascending aorta. Usually these patients will have arthropathy associated with the bicuspid valve, and these patients are followed closely to be sure that these aortas are not getting dilated over time. This particular case was 4.6. And notice too that the LVOT diameters are usually larger. And the LVOT is never around, is more oblong. The right peristernal views are ideal for this type of assessment of this aortic valve because they tend to have eccentric jets of stenosis and insufficiency. And you can appreciate here the AI as well as the turbulent flow within the valve. And this is the best way to calculate the gradients because in the other views you will underestimate. This jet is going anteriorly, and when you do in the apical views from the forechamber, the jet may be underestimated. This particular case had moderate aortic stenosis with 40 for peak gradient mean of 27. You can also appreciate the degree of AI. Ideally, if the patient allows you, you can estimate or calculate your valve area by the 3D. The 3D allows you to do multi-plane and focus on the tip of the valve. It's where normally the aortic stenosis will be present. And then you can planimetry the valve and then directly measure the valve area. You can see it here and here, and then you trace your aortic valve. So these valves can also have a lot of insufficiency, and usually they are very eccentric jet. This one in particular is posteriorly directed towards the mitral valve, and the mitral valve can have limiting to opening, and you can hear a similar Austin Flink type of murmur. And then ideally, if you have 3D, you can appreciate the ERO or the vena contracta of this very eccentric jet of AI. That the pressure half time may be not suitable because of the eccentric jet. In the apical 5-chamber view, you can appreciate the thickening of the aortic valve and the eccentric jet posteriorly directed, closing, allowing the mitral valve not to open normal, and then wrapping around along the lateral wall of the left ventricle. So if you want to see the degree of AI, if there is any reversal flow within the aortic arch, then that suggests that the aortic insufficiency is severe. So you see this red flow in diastole here in the descending aorta. That is suggesting severe AI. When you put the Doppler, you will appreciate this is the reversal flow. And if you do your VTI, in this case was 20, that's consistent with severe aortic insufficiency. Moving now to the unicusp. Unicusps are similar to the bicuspid valve, but you can appreciate that there is one single leaflet that has some doming and some stenosis at the opening. In this 3D, you can appreciate the one leaflet. It looked like raphe, but it's truly one leaflet, and it looks like a toilet seat when the valve opens. That's characteristic of this unicusp aortic valve. For the quadracusp, I have two examples. They're very rare, and it can be associated with an ASD, pulmonary stenosis. But in this particular case, you have a non-coronary cusp, a right, and then the left is sort of divided in two, as you can see here. And there is a little bit of lack of coaptation right in the middle where the thickening of the leaflets are. Versus this other example where you see the left cusp, the none, and the right appears to be divided in two. And again, these valves can have aortic insufficiency as well as stenosis. So bicuspid aortic valves can be associated with coarctation of the aorta. And the best and only shot to rule this out is the suprasternal notch, where you're going to look at the entire aortic arch, and then descending aorta after the left subclavian artery, you'll see a narrowing. By the color Doppler, you will see some turbulent flow. And when you run the CW, you'll see that there is a tailing in diastole due to the significant obstruction of the descending aorta. When you're measuring the gradients, we like to do the modified Bernoulli equation, and would you have to measure the V1 before the obstruction, and then V2 to truly measure your gradients, that it will match your cath. In the subcostal view, at the level of the abdominal aorta, you will see that the aortic flow looks continuous, and that's because of the obstruction above. And when you sample the pulse Doppler, you will see that there is a little blunted systolic flow, but a very prominent diastolic. And this is not a normal Doppler of the abdominal aorta. And this is consistent with significant coarctation. Those are the views that truly will tell you if the patient has or not coarctation of the aorta. Moving now to the pulmonary valve stenosis, as the word says, the pulmonary valve is abnormal, is narrowed, and it presents with some right ventricular hypertrophy on the parasternal long axis view. You can see that RV can be also dilated, like in this case. And in the short axis view, or the biplane of this pulmonary valve, it has some doming similar to what you see on bicuspid aortic valves. And the base of the leaflets are mobile, but the tips are fixed, as you can see here. And when you put the color Doppler, you will see that there is an acceleration of the blood flow within the leaflets of the valve. In some cases, you can also have supravalvular pulmonary stenosis, and you want to be sure, because if the patient is going to have a balloon valvuloplasty, it's ideal if it's just a valve, but if it's above, it could be a difficult case. There's also some pulmonary insufficiency associated with, in this case, is mild. The continuous Doppler will be run right along the area where you see the narrowing or the turbulent flow here by color. And then you can just trace it and measure your gradients. In this case, it's severe. The gradient for stenosis are here below, where severe is above 64, moderate is 30C and 64, and this patient had 119. Also noted that this jet here, its diastolic forward flow is seen when the right ventricle has some restricted physiology. The pressure in the right ventricle at the end of diastole is so high that allows blood to lead out to the outflow tract. In the short axis, you will appreciate a D shape along the septum due to the pressure load of the right ventricle. There is significant right ventricular hypertrophy from the significant pulmonary stenosis. And you can see what a normal short axis looks on top. And in the 4-chamber view, you appreciate that the right ventricle is dilated and is severely hypertrophied if you look and compare to a normal right ventricle on top. Moving to another case, are the Cor Triatriatum Sinister. These are very rare cases. And it's the lack of failure of the pulmonary veins to incorporate into the left atrium, leaving this membrane along the atrium, dividing it in the upper and the lower or superior and distal chambers. the color flow will determine where the defect is within the atrium. And there is definitely an obstruction mimicking mitral stenosis. So the pulmonary veins will drain here and then obstruct flow and then leading out to the distal part of the left atrium. In the short axis, you can appreciate the anatomy of a Cor Triatriatum Sinister, where the pulmonary veins are draining into the superior portion of the atrium. And then the distal portion will have the left atrial appendage and the mitral valve. And the color flow in the middle demonstrates the true orifice and the stenosis of the pulmonary veins. In the apical four-chamber view, you will appreciate the pulmonary veins into the superior portion of the atrium, the membrane dividing the two, and then the flow demonstrating the significant stenosis. And here the Doppler will demonstrate a mean gradient of 9 or 10, and this is the flow from the left pulmonary veins into the distal portion of that Cor Triatriatum Sinister. And then here's some 3D demonstrating the same views that you see pulmonary veins draining into the superior portion. And then here you will see it nicely. And the orifice is right here in the middle. This is the distal portion and the mitral valve. Now moving over to the anomalous coronaries, we're going to start with the ALCAPA, that stands for anomalous left coronary artery from the pulmonary artery. So in the peristernal long axis view, you can start to see with the color that there is an unusual flow, blue flow here along the interventricular septum. This is your left atrial, your LAD, your left anterior descending artery, that is actually running reversal because it's going into the pulmonary artery instead of the aorta. In this short axis view, you will see that the normal flow will be red and blue, and in this case, it's going red and blue into this direction. It's reversal because the left coronary is coming off the pulmonary artery, and because the pulmonary artery pressures are lower, then it's caused a still of the coronary flow. So the flow will drain directly into the PA instead of coming out. And also the hypoxia due to the flow from the PA that is lower oxygen level than the aorta. So again, the reversal flow, and here this red is the flow into the PA. And you can see that the coronary is arising from the pulmonary artery and not from the aorta. Usually these cases have a very large right coronary, and the right coronary have a lot of collaterals that it will be feeding that left coronary anomalous artery. You can see it here in the subcostal view, where you see all the collaterals along the RV free wall. And in this case, the apical four-chamber view shows a normal, relatively normal ejection fraction, but there is a bright echo density along the papillary muscle, and this is due to ischemia from the hypoxia due to the ALCAPA. The two-chamber view shows also this bright echo along the anterior wall. And we will just say that this ventricle has normal ejection fraction. However, the systolic function is abnormal if you look at the strain in this particular ventricle. So EF doesn't truly tell you what the systolic function of the ventricle is. Always look at your strain. The other very rare, and this is a courtesy of our pediatric colleagues that share this image with me, is that the ALCAPA anomalous right from the pulmonary artery. So the pulmonary artery is coming up here, and this is the right coronary arising from the PA. Again, the flow will be into the PA. You see back and forth because the pulmonary artery pressures are lower than the aorta. And then you can see it here going into the PA and going around. The right PA, the left PA, the aorta here. So the right PA coming off the pulmonary artery. Moving now to the most common one is the anomalous right from the left cusp. And then I just put a picture up here so you can appreciate what a normal right coronary should look like. This is the right cusp, your right coronary. But in this case, by the color may be the only way you can appreciate the anomalous origin of that coronary. This red flow directs you to where the origin of this right coronary is originating from. The left coronary is here, and this is the right. And then you can appreciate this. There is an intramural course in order to reach the right side of the normal course. This is the left coronary over here. The other one is the left from the right cusp. In this example up here, you see the normal course. This is the LAD, and this is the circumflex. But in this particular case, you see that the left coronary is originating from the right cusp and going down into the intra-arterial course into the area of the septum. This blue flow demonstrates the anomalous left coronary artery. And in this case was a single orifice where you see the right and then the left and then the intra-arterial course. This is the pulmonary artery and this is the aorta. This is another case of the anomalous left from the right, and the color flow will be the only way that you can appreciate the course of this of the coronary flow. So always be sure that the equipment that you're using has appropriate presets to evaluate this this type of anomaly. Again, you see the left coronary coming here, and then the course anomalous between the two arteries into the septum. And the other one and last is the anomalous circumflex from the right coronary artery. And this is a very benign course, and the circumflex originates from the right, and this blue flow tells you the trajectory of the flow down and sorry about that. The retro aorta, in here, you see the circumflex. This is the aorta. This is the left atrium. You see the course down here. And in the apical four-chamber view, a little bit more posteriorly tilt, you see that this vessel coursing here is the circumflex to reach out into the lateral wall. And I think with this, I am going to stop here. I thank you very much for your attention. And next week, more complex cases will follow. Thank you very much.
The preceding program is copyrighted by Emory University.